Hi, thank you very much for the invitation to come and talk about splenectomy. I think this is a really interesting topic, some of you may well have had a splenectomy, some may not. So it'd be interesting to see what you think about some of the things we're going to discuss today. So yeah, what is the place of splenectomy in ITP? I'm Vickie McDonald. I'm a consultant haematologist at the Royal London and also chief investigator of the UK ITP Registry. These two pictures are of the Royal London and also of our university. So we can't really talk about splenectomy without talking about what the spleen is, what it does, and therefore why we might need to remove it. The spleen is a small organ at the top of the abdomen on the left-hand side, and it's important in fighting infection. It's an important part of the immune system, but it also removes old or damaged blood cells, and so it avoids a buildup of cells that aren't able to work so well because they've become a bit older. And splenectomy is removal of the spleen, which could be via surgery and an operation. That could be an old-fashioned big cut in the tummy, or it could be via camera endoscopically, laparoscopically, sorry, or it could be now via more clever radiological methods where they block off the circulation to the spleen. So what's the role of the spleen in ITP? So if you look at these pictures on the right-hand side, we can see that in the pink box, we've got platelets that are coated with antibodies, and these are taken into the spleen and broken up, and platelets are got rid of from the body that way. But in addition, the spleen also is important for developing the cells and allowing development of the cells that make antibodies to platelets in ITP. So it has a couple of different roles, and therefore historically there was certainly rationale for taking somebody's spleen out in ITP. And I say historically because if we look at the use of splenectomy in the United Kingdom, and this is data from the UK ITP Registry, some of you may be part of this through your hospital, we can see that 30 years or so ago, we were taking spleens out in about 35% of the patients that need treatment. But actually that's starting to reduce by kind of 15, 20 years or so ago, as we've got more medical treatments. And certainly in the last kind of 10-year bracket, we're doing splenectomies in way less than 5% of patients in the UK. So it's quite a dramatic drop over time. And I've put the other treatments in there for you to see that actually it's an association with an increased use of medical therapies, in particular rituximab, maybe mycophenolate that control the immune system, or more specifically romiplostim and eltrombopag, which are more targeted treatments for ITP, for which we've got quite a lot of data on their effectiveness. So we thought, right, well, if we're not doing very many, let's have a look at how patients are responding, what the outcomes might be. Can it give us some clues as to when to use it? So we did have a look last year, did an analysis of all the patients who'd undergone splenectomies that had been entered in the registry. And at the time we did the analysis, we had over 4,000 patients registered into the registry, of which 360 had received a splenectomy. There were some that we couldn't analyse because maybe the data was quite old and we didn't have all the information that we needed to make sure it was a fair comparison. So we were left, having taken those out, we were left with 347 patients for analysis. And they'd received a splenectomy between 1951, a long time ago, and September 2019. And the total patient year follow-up, to give us an idea of whether there was enough follow-up to make good conclusions, was over 3,500 years follow-up. So pretty good all round. So what did the patients look like that were undergoing a splenectomy? So the average age was 40 years. Although just over 10% were older than 65 years. And that is important when we come on and look at some of the responses a little bit later in the talk. 60% were female or just over, and just under 40% male. And that's in keeping with the average age being 40 years, because we know in patients under the age of 60, ITP is more common in women than men, and over the age of 60 is more common in men than women. The average follow-up is just over 7 years. And the average time to splenectomy is just under 1.5 years. So we thought, well, let's look at whether we were doing splenectomies at a different time in a patient's ITP treatment journey, as it were. So were we doing them earlier, later, historically? Are we doing them earlier, later now? And again, we divided into those 10-year age brackets or time brackets that we were talking about before. We can see again in the top row of this table that the percentage of patients undergoing splenectomy is falling over time from nearly 35% to under 5%, so just nearly 4%. And the average time to splenectomy is increasing. It may not look much on there, but it is significantly different. The third row down, the average number of treatment or different drugs used before splenectomy is going up. And the average number of times patients need treatment before reaching splenectomy is also going up. Now, this is an average, so there might be some under that and some over that. But we are definitely doing splenectomies later on. We're not doing as many, and we're doing them later on in the treatment pathway. Patients have received a whole variety of treatments before getting to splenectomy. On this table, there's quite a few of the more old-fashioned treatments, or what we would think were old-fashioned treatments now: danazol, vinca alkaloid, so vincristine, cyclophosphamide. And that's because a lot of these splenectomies were done a long time ago, and so patients were receiving those types of treatments, whereas now we would be seeing, if we divided this into age brackets, a lot more romiplostim, eltrombopag, rituximab, mycophenolate being tried before splenectomy. So how do patients respond to splenectomy? Well, so this chart shows us PR, a partial response, CR, what we call a complete response, and OR, which is the two added together to give an overall response. And the complete response is a platelet count of over 100. That's a fairly standard definition that we use in the literature for being able to compare trials and studies. Partial response is a platelet count between 30 and 100, and no response would be then a platelet count of less than 30. And the overall response adding together. So we can see there's an overall response rate at a month of about 90%, but it does tail off over 6 months, a year, and 2 years down to less than 50%. And that's interesting because I think historically there are charts that we can see of studies of splenectomy showing that actually there's response rates even to 80% out at 2 years. I think that is when you select your patient group quite carefully, and we'll come on to that a little bit later. So if we do this, we're thinking now that we are doing splenectomies later and often after other lines of treatment, where perhaps we've tried 2 or 3 lines of treatment, maybe 4 lines of treatment, we're not winning, your platelet count's still low, you don't feel great, maybe needing quite a lot of courses of steroids to keep the platelet count safe. So do we see a difference in how patients respond to splenectomy if it's done at different times? And this doesn't mean to say if you respond better by doing it earlier, that we should be doing it. It was just, do we find that actually if you do it later you might run into problems with response rates? And so overall the average response is about 4 years, so it's quite a long time, but we can see in the 89 to 98 time bracket that average was 9.6 years, whereas actually over time it does fall. Now obviously the most recent group don't have as long as an opportunity for follow-up. But if we divide these groups by under 65 and over 65, we can see that certainly in the under 65-year-olds, we have a much longer average response, whereas in over 65, it's much shorter. And that isn't a surprise. We do know that patients who are older don't respond as well or don't have as long-lived a response to splenectomy, possibly suggests something slightly different about the mechanism of ITP. But it confirms that, and I think reinforces that if you're a patient over the age of 65, there may be a good reason to do splenectomy. The clinical team may feel there's really nothing else and you're totally up against it and really super poorly. But in reality, if there's an alternative, then alternatives probably should be chosen for those over 65, although not always, and it may be suitable. And some patients over 65 do respond. So if we divide then, if we look at the top line is looking at the influence of age on time to next treatment. So that chart at the top, at the very beginning of the chart, we've got 100%, so 100% survival or 100% not relapsing. And then over time, how many people are coming to the next treatment. So it's called a survival estimate, but actually it doesn't mean whether you're alive or not alive. It means whether you've reached a point we're interested in, such as needing another line of treatment after your splenectomy. And the blue line at the top is the under 65 group, and the red line at the bottom is the over 65 group. And we can see that the over 65 group drops off much more quickly. So they're moving to next line of treatment much more quickly than the over 65 group. So that's really a picture representation of what we just talked about in the last slide. If we look at the bottom slide, red is female and blue is male. The rate of change of that curve is the same for gender. So it doesn't matter whether you're a man or a woman. It doesn't influence whether you need to get to next treatments and your splenectomy fails more quickly. So what complications do we see after splenectomy? So splenectomy is major surgery, whether you have a big open operation or you have a laparoscopic operation or whether you have a radiological, it's still major surgery and removal of an organ from the body. And we do know that there are significant complications associated with taking patients' spleens out. So 15% of patients had thromboses, and these were either venous or arterial, and the average time to thrombosis could be quite a long time after the splenectomy. So it's a long lasting, it's not immediately after you do the operation. It's not perhaps like when you're taking other medicines where the side effects are around when you're taking the medicine. And if we stop that medicine, you don't get the side effect. Actually, the side effects of splenectomy can last quite some time. And nearly 13% of patients had infections, most of them, single figures, but some patients had recurrent infections after splenectomy. And there were 13 deaths in this group, but only one attributable to splenectomy. So actually, there wasn't a significant what we call mortality, death rate with splenectomy, but certainly quite a significant complication rate. So it isn't without its complications, and it's major surgery you have to go through. So if we think, well, there are complications associated with splenectomy, and sometimes patients may not respond, can we try and predict who might respond? And the answer is yes. We can do something called an indium labeled platelet scan. And that is a scan where we take the patient's platelets. So we take a blood test, we label the platelets with indium, and that can be detected by a special machine. And then we give the platelets back and we look to see where that indium concentrates. So where you see kind of heavy concentrations of indium. And we know that if most of the destruction of platelets, so where those platelets go that are labeled with indium, if the destruction is mostly in the spleen, then patients do much better and the responses are much more long-lived. So this is a picture here, the type of thing that we see in, these scans are done at a couple of places around the country, but one of those is Bart's Hospital, which is part of the trust that we work with. And Professor Newland and I will go and have meetings and have a look at the scans with the team that interpret them. But this particular image, where the black is concentrated, is where the spleen is. And to the left of that, the triangular shaped organ is the liver. And just above that is a background so that they can see whether the concentration of the indium or the dark colour is greater than background and work out the ratio. And in this picture, this is a predominantly what we call splenic sequestration. That's a big posh word for the platelets are mostly going to the spleen to be destroyed. Whereas in this picture, you can see the difference. So we've got a concentration of dark of indium both in the spleen, but also in the triangular shaped liver organ. So this is a mixed sequestration. And patients that have mixed sequestration or predominantly liver sequestration or liver destruction of the platelets do not respond well to splenectomy. And that would make sense, wouldn't it? I mean, if most of the destruction's taking place in the spleen, then there's certainly a common sense approach of, oh, well, it's likely that the splenectomy would respond, and that's borne out by clinical studies that have been done previously. So what's the summary then from kind of what are we trying to say about splenectomies for ITP? So the use of splenectomy for ITP as a treatment has fallen quite dramatically since 1989 in the UK. We've got a lot of very good medical treatments for ITP, and actually I think that it's an exciting time for treatments in ITP. We've got some very good established targeted medical therapies. We've got more information about how best to use immunosuppressive therapy, and we've got novel therapies coming through. So we don't need to do major surgery on patients anymore to put their ITP into remission. We know that the response is a lot less long-lived in patients who are over 65 than under 65, and therefore embarking on a splenectomy, certainly in someone over 65, really has to be with you've got no other options left. And there might be one or two targeted ways that it might be helpful. And I think we have to be very mindful of the short and long-term effects of splenectomy. While yes, it can be very effective, just weighing up those pros and cons and having a discussion with your doctor if somebody talks about a splenectomy is very reasonable. And one thing we haven't really had time to touch on is vaccination, and there is an overwhelming risk of infection. So there are certain vaccinations that you need to have, ideally before a splenectomy, or if you have to have your splenectomy in emergency, you do them afterwards. So when do we use a splenectomy? So this is from the International Consensus Guidelines, but I think as a broad rule of thumb is what we would do in the United Kingdom, waiting 12 to 24 months from diagnosis. We don't do a splenectomy unless the thrombopoietin receptor agonist discontinuation is tried and then not working. Ideally platelets over 50 pre-splenectomy, but that can be challenging and you might have to do it with platelet count support. As we've discussed, there's a higher rate of relapse, so really careful in patients who are a bit older, and certainly there's a recommendation to use these predictive studies like the Indian labelled platelet scans. So I just wanted to say a huge thanks to all those patients and staff members who recruit patients into the registry so that we can start to make these conclusions. To the registry team and our clinical fellows who've helped us look at this data, in particular Sophie Todd, but also to the Support Association who were very supportive of this, and we're very grateful for the collaboration between the two. So thanks very much, and if there are questions we'll be able to take them a bit later.